Mm, Hello, hello all. The topic for today's discussion is going to be your Endo Perio Lesions. So it's a very important topic as far as concerned. These are the contents. So coming to introduction, the pulpal and the periodontal problems, they are going to be responsible for more than 50% of tooth loss. What is this perioendo lesions? Perioendo lesion is nothing but coexistence of both the pulpal and the periodontal disease in the same tooth. So this could have occurred independently by or pulpal and periodontal independently, or one disease could have led to the other disease. Okay. So coming to the history, you should definitely know about history. Turner and Drew is the person who just established the periodontal relationship on the pulp. And Simring and Goldberg, they have established that there is some interrelationship between the pulp and the periodontium. And in addition, Kahn and Seicher, they have pointed out that there is some developmental connections between the pulp and the periodontium. So what is this developmental connection? For example, as we all know, this ectomesenchymal cells, they are responsible for the development of the pulp and the periodontium. So ectomesenchymal cells, they differentiate into dental papilla and the dental follicle. So dental papilla cells, they differentiate into pulp, and dental follicle cells differentiate into periodontium. Thus, there is some kind of embryological connections from the stage of development, from the early stage of development itself. And what are the pathways connecting the endo and perio lesions? So first we have to know about developmental origin. As we all know, apical foramen, axillary canals, lateral canals. So this is going to serve as a pathway between the pulp and the periodontium. Okay, so direct pathway between the pulp and periodontium. There is no need for any disease if there is presence of apical foramen, axillary canal, lateral canals. It's going to provide direct pathway between the pulp and the periodontium. And then developmental groove, and also dentinal tubules. Even dentinal tubules, suppose the cementum is absent, this is going to provide direct connection between the pulp and the periodontium. And also pathways of the pathological origin. So here, that is root fracture following trauma, idiopathic root resorption, internal and external, loss of cementum due to the external ligands. So these are the pathways of the pathological origin. Okay, like normally the tooth is fine, but after root fracture, after resorption, after loss of cementum due to external ligands, this is going to provide a pathway between the pulp and the periodontium. And iatrogenic origin. Iatrogenic origin is also similar to pathological origin. If we are going to do root planing, that is iatrogenic is what we do. Suppose if we are going to do root planing, it is going to expose sentinel tubules. Suppose if we are going to do a lateral root perforation, suppose if we're going to do lateral root perforation, similar to fracture, this is going to provide a pathway between the endo and the perio thing. So same way, etiopathogenesis is nothing but similar thing only. This is going to have the anatomical connections. One is apical foramen, lateral canals, and internal tubules, and contributing factor is what I told. That is the trauma, resorption, perforation, malformation, etc. In addition, it's going to have a etiological pathway, which is live pathogens and non-living etiological agents. Live pathogen is nothing but there are few bacteria, virus, and fungi which is common to both the perio and the endo lesions. So one such is going to be your actinomycetin comitans or Prevotella, Porphyra minors. I'm just giving you a few examples. Fusobacterium, etc. They are going to be common to both the endo and the perio lesions. Okay, so I also have to tell, like, this endo lesion is going to be less complex compared to perio. Perio is going to be more complex compared to endo. And non-living etiological agents. And here, non-living etiological agents is going to be your other things like extrinsic and intrinsic thing. For extrinsic thing is nothing but your gutta perca. If you're going to introduce a gutta perca, that is going to, suppose if you're going to have an extrinsic gutta perca, that is going to act as an etiological agents. And your calculus, which is a non-living etiological agent between the pulp and the periodontium. And other than this, your cholesterol clefts, etc., is going to be an intrinsic etiological agent. So yeah, and we have to definitely know about the classification. which is used for the Endo Perio Lesion, given by Simon, Glick and Frank. This is the most common classification, which is given in 1972 based on etiology. They're classified as primary endo lesions with secondary periodontal involvement, primary periodontal lesions, primary perio with secondary endodontic involvement, and true combined lesions. So here, this classified based on etiology. You have to understand this. The most important classification. This has been modified by Stock, whereas the true combined lesion has been removed because the primary endo lesion with secondary perio involvement and the primary perio lesion with secondary endodontic involvement both are combined lesions. Hence, both is going to be a combined lesion in the future. Hence, this true combined lesion classified has been removed by Stock. This is a diagram which is going to depict about your primary endo, secondary perio. How this is the primary endo. Only here we are going to have only endodontic infection. Okay, as we see here, only endodontic infection, and primary perio is only periodontal infection. There is no interconnection here. Primary perio. So you will understand in depth when I talk about pathogenesis. Here, primary endo, secondary perio is you're going to have your endodontic infection first. So this is going to enter. This is going to lead to perio infection. Okay. See, this is going to enter the sulcus via your here all these things. It's going to enter sulcus via your lateral canals, apical foramen, etc. And this will again lead to perio. This is going to attract the plaque and calculus, and this is going to cause your secondary periodontal infection. And primary perio, secondary endo here. This is nothing but first you're going to have a periodontal infection, and this is going to enter the tooth via your lateral canals and via your apical foramen, and this is going to cause an endodontic infection. And combined lesion here, we're going to have a separate endo and perio lesion, and this is going to combine together to cause the disease. Okay. And not only this Simon, Glick and Frank classification, there are other classifications given by Wayne, Grossman, Torabinge and Rope, and World Health Organization, etc. So these classifications, I'm not going into depth, but you have to at least know based on what it is classified. So like for Wayne, he classified Endo Perio Lesion based on clinical presentation, and Grossman based on treatment need. What treatment is needed, whether endodontic treatment is needed, periodontal treatment is needed in that way. And Torabinge and Rope, he classified based on the origin of the periodontal pocket, and World Health Organization based on origin of the disease. Like which disease has originated first, like endo perio or perio endo. In that way they classified. And Khalid Al-Fawjan, this is a recent classification. He modified the primary. That is a most important classification given by Simon, Glick, and Frank, and he classified and proposed a new classification where he modified the primary endo lesion. As far as him, his primary endo lesion is not going to have any perio involvement, and that's why he modified the classification, and he named it as retrograde periodontal disease. So this is the pathogenesis. Primary endo, here only endodontic infection. Okay, only endodontic infection. This is going to enter into your like this endodontic infection is going to cause any periapical changes alone, or this may cause any forcation changes alone, for which we will do a normal RCT and everything will be fine. This is the primary endo. And same way, primary perio is there is no endo involvement. Okay, only perio. So here, because the plaque and calculus or something else, only primary perio. There is only the problem with the supporting apparatus of the tooth and nothing regarding your tooth. Only the supporting apparatus of the tooth. And the secondary perio, primary endo, secondary perio. Here, first we have this endo infection. That is, there is some problem within the tooth structure. Okay, there is some problem with tooth structure. This is going to this is going to leave some exudate. Okay, this is going to leave some exudate here in the sulcus, etc. And this may attract the plaque, calculus, etc. And this may cause again the apical migration of your junctional epithelium, causing secondary perio infection. So here we are going to have an endo infection, primary endo, and secondary perio. This is going to lead to secondary perio infections. Secondary endo here. Secondary endo is first primary perio, secondary endo. Full form is primary perio, secondary endo. First infection is going to be perio infection, and this is going to enter into your tooth and cause endodontic infection via your lateral canals, via your apical foramen, etc. Okay, it's going to enter here and it's going to cause a problem here. And combined lesion is this may occur independently, like endo infection could occur independently. and coincidentally on the same tooth perio infection could occur. Okay, so or both could have reached the advanced stage. On one advanced stage, how is going to meet together, and this is called as a combined lesion. So this clinical and the radiographic test for diagnosis of endo perio lesion is a very important and very interesting aspect. First thing what we have to know is pain. So pain, when we ask a patient about pain, if the pain is sharp, it's going to be a primary endo. For example, I'm just going to tell all the endodontic infection is going to have a sharp pain, whereas all periodontal infection is going to have a dull ache. Okay, dull ache. So suppose if it's primary endo and secondary perio, since endo is a primary thing, it's going to have usually sharp shooting pain. Primary perio, secondary endo is going to have a dull ache because it's a perio, and in combined lesion it's going to have dull ache only. Okay, this is the first aspect. So once you see the patient, you can just ask them how is the pain, whether it is sharp or whether it is dull. If it is dull, it's a perio thing. If it is sharp, it is an endo thing. And the next one after that, you can ask them to sit and you can just ask them to open the mouth and visually you can examine without doing any other examination, just visual examination. So when you see the tooth with the caries, extensive restoration, discolored crowns is usually associated with endodontic infections. Okay, the absence of any obvious corneal defects in conjunction with the plaque and calculus. So if you're going to see plaque and calculus in the tooth and generalized gingivitis or periodontitis without any caries or extensive restorations in a tooth, that is going to indicate the periodontitis. This is as simple as that. Okay, when you just, if the patient comes with pain, first you can just ask how is the pain, and then you can just ask them to open their mouth and see how is the defects here. Okay. Then afterwards, what will you see in your visual examination? Not only the whatever the caries you can see, you can also see some swelling. Okay, swelling often localized to the fistulous tract opening in the apical area. If the swelling is in apical area, this is going to be endodontic infection. Suppose if it is going to have a generalized swelling, so it is going to around the involved tooth, it's going to be a perio infection. So this is based on the visual examination. In primary endo, it's going to have a tooth which is full of, which may be decayed, which may be cracked, which may be root canal treated, or which may be erosion, abrasion, etc. And primary perio, it's going to have plaque and subgingival calculus. Okay. And the distinguishing feature, like primary endo is going to have more of the endodontic lesion thing. Okay. And primary perio and secondary endo more of periodontal infection thing. That is the difference here. And in true combined lesion, can see everything: plaque, calculus, periodontitis, every swelling around singular, multiple teeth. Okay, everything could be seen here. And palpation and percussion, they are not very effective in discriminating between the periodontal and endodontic infection. But however, to some extent, palpation of the coronal soft tissues is indicative of gingivitis and periodontitis. And palpation over the root apex of the tooth with pulp necrosis indicates the presence of the periapical lesion. So, if it is in the root apex, if the patient is going to have pain in the root apex, it's going to have it's going to be an endodontic infection. And percussion, see, whatever, if there is going to be any infection or an inflammation, there is going to be pain on percussion, tenderness on percussion. So here it is going to be similar for all the things: primary endo, primary perio, primary endo, secondary perio, primary perio, secondary endo, true combined lesion. For everything, there is going to be pain on palpation, tenderness on percussion. This is not very much discriminative diagnosis, but you can just see whether the palpation, pain and palpation of the coronal is going to be of perio origin and the apical is going to be of endo origin. And mobility. So as we all know, mobility is the most common phenomenon in case of the perio infection, not in endo infection. So hypermobility is quite common in case of the, but however in primary endo infection, if you're going to have a primary endo infection, there is going to be hypermobility because the presence of the inflammation. So after doing root canal treatment, this hypermobility is going to subside in case of the endodontic infection. But mobility is a common feature for all the perio infection. See, primary endo, suppose if there is a recently traumatized teeth or there is more of inflammation, there is going to be localized mobility. That is in case of only one tooth. And in primary perio, there is going to be localized to generalized mobility. And primary endo, secondary perio. See, always remember that endodontic infection is going to have only localized mobility, whereas perio is going to have only, perio is going to have all generalized mobility. Okay, generalized mobility will be dealt with the perio, primary perio, secondary endo, all perio, and all endo is going to have your localized mobility. And vitality test, we all know that this vitality test is an important thing, but this can easily discriminate. Suppose, for example, why perio lesion is going to have a poor response or no response. Perios has nothing to deal with. For example, primary perio has nothing to deal with without any embryonic infection. See, all the perio infection is going to have a positive response, positive pulpal response, whereas all the embryonic infection, it may have an exaggerated response to heat or cold because of irreversible pulpitis or with it with necrotic pulse. Okay. There is no response. So vitality is an important diagnostic aid which could discriminate easily between the your pulpal and the periodontal problem. So in case of embryonic infection, no response, it is necrotic pulp. In case of periodontal thing, pulp is going to be vital. Okay. In primary perio, secondary endo, that is after getting a perio infection, only 1-2, there is going to be endo. In that case also, it may be positive because of multi-rooted tooth. So in any one canal, if the pulp is vital, this may show a positive response. Okay, so you have to just remember this alone. And pocket probing, pocket probing defects, all the perio pockets are wide because of the bone loss. All the perio pockets are wide and they are shallow. So shallow in the sense there is no need for any deep pockets in the perio infection, and only in the pulpal thing there is going to be narrow and deep pockets. Okay, narrow pockets in the pulpal, and in the perio it's going to be wide and shallow pockets. Embryonic probing embryonic probing, in one aspect, when you just do a probing thing, suddenly there will be a drop and there will be depth in the probe, increase the depth in the probing thing. In that is typical embryonic probing. Whereas typical periodontal lesions, it is going to have a conical contour. It's going to have a conical probing like this, gradual decrease in the probing thing. Whereas embryonic probing, here it's going to have a sudden decrease in your probing depth. Okay. That's why this typical lesion in periodontal thing is going to be conical in character. So it's going to have primary endo is going to have a narrow solitary pocket. That is only 1 or 2 pockets. Whereas primary perio is going to have multiple wide and shallow pockets. Sinus tracing, when you use this Gattapaka to trace the sinus. So here the sinus tracing will end in the apical foramen or the lateral canals in the case of embryonic origin, whereas in the case of periodontal origin, this is going to end in the lateral aspect of the tooth. Okay. So apex of the forcation areas in case of endo, or lateral aspect of the tooth in case of perio. Same way. See, don't want to confuse between this and this. Okay. So similar to this only. Primary endo, secondary perio is almost endo. Along with that, there may be secondary perio characters also. Okay. Primary perio and secondary endo is full perio. Perio, along with that, there may be some characteristics of embryonic infection. Radiograph is also an important aid. For example, all the periodontal lesions, they're going to have an angular bone loss extending from cervical region to the apex. A periapical, for example, this endodontic lesion is going to have an destruction of the apical periodontium, which occasionally extends coronally towards the CEG. So localized or generalized bone loss. If you're going to have a localized generalized bone loss, it is an important radiographic feature to discriminate between the pulpal origin and the periodontal origin. Localized bone loss is going to be your embryonic thing, and generalized bone loss is going to be a periodontal thing. You can just identify the crestal bone in relation to CEG with the help of these lines. This is a perio infection. So the radiograph is the primary endo lesion, primary perio lesion, primary endo, secondary perio. Why it is primary perio? So you can see bone loss, horizontal bone loss. Primary endo, you can see here bone loss at the apical thing. At the coronal thing is primary perio. Primary endo and secondary perio. Because of this has led to the bone loss here. You can see secondary perio, primary perio, secondary endo. So it has a generalized bone loss and an embryonic infection. Secondary perio and true combined lesion. So how to discriminate is, if you're going to have a generalized bone loss, along with that, the bone loss in only one particular tooth is going to be primary perio and secondary endo. And endodontic infection and periodontal infection, only one tooth is going to be primary endo, secondary perio. And this is very easy to discriminate, primary endo and primary perio. And cracked tooth testing is going to be positive only for endodontic infections. Only for endodontic infection, because there is nothing to deal with periodontal thing. So this is a pure endodontic origin. This is a test called transillumination where you can see the fracture lines. Okay, this is an endo origin thing. So, and the other differentiating features, we all know this pulpal infection is going to be non-vital, periodontal is going to be vital, and plaque and calculus is not related, and here is going to be the primary cause. Inflammation is acute in pulpal, and periodontal is chronic. And pockets, you have to remember, it's going to be single, narrow, and deep in pulpal infection, multiple wide in periodontal infection. pH value is going to be acidic and alkaline here. Trauma is going to be primary or secondary. Here will be the contributing factors. And microbial is going to be complex in the periodontal infection, not the pulpal infection. So radiograph, it is going to have a localized bone loss in case of your endodontic infection, and generalized bone loss in case of your periodontal infection. And histopathology, there is no apical migration of junctional epithelium in endodontic, but in perio it is there. And granulation tissue will be present apically for endodontic and for coronally for your periodontal infection. And treatment, we know RCT for endodontic and periodontal therapy for perio. So coming to treatment, initially you're going to have, what is the initial management? So if the patient comes, first we are going to remove all the existing restoration, and we are going to chemomechanically prepare canals and medicate canals. After medication, we should not directly go to RCT. Okay, this is a generalized treatment plan. Awards criteria is not specific to one particular thing. Generalized for all site classification. I'll just deal about one particular thing too. And we're going to change the intracanal dressing after 3 to 4 weeks. And we're going to review the periodontal healing after 3 months without doing obturation. And then we are going to reassess the need for further periodontal treatment. So if more periodontal treatment is needed, example, surgery, we are going to change the intracanal medicament again. If the healing response is favorable, we are going to complete the root canal fielding, and then we are going to do the surgery. So we are going to change the intracanal medicament, and we are going to see whether it is enough for the resolution, whether there is any resolution of the periapical changes. Okay. Suppose if it is because of endo infection, definitely there is going to be resolution of the bone loss. So that is the thing. So for if the primary endo lesion, what is the management for primary endo lesion? So obviously primary endo lesion may also have sinus tract. Okay, but this could have gone after your treatment, after doing RCT. This heals on its own. This has nothing to do with the sinus tract. So just if you do your BMP and obturation, this will heal on its own. This is a primary endo. So with the help of this calcium hydroxide, which acts chemically, physically, and biologically, even a large periapical lesion, we can slowly we can manage by a non-surgical management instead of any surgical therapy. And coming to primary periodontal lesion, in primary periodontal lesion, first we're going to do hygiene phase therapy and poor restoration on developmental grooves, which are removed, and periodontal surgery is performed after the completion of the hygiene phase. So separately, whatever the perio treatment we are going to do, that will be done in the primary periodontal lesion. And in primary endodontic lesion, we are going to do all the endodontic treatment. So here, that's it. So after, while doing any primary hygiene phase in primary perio, you should be very sure that you have to minimize the use of ultrasonics and rotary scaling instruments to avoid the effects, irritating effects of the chemicals towards the pulp. Though this should not be an iatrogenic error which causes any pulpal infection. Primary endo and secondary periodontal lesion. So this is primary endo. So first we are going to manage endodontic infection. So you're going to do an access opening. You're going to place the medicaments, intracanal medicament, and then we are going to observe. We are going to have an observation period for at least 3 months. We'll just see whether there is any resolution of the treatment. and then we are going to consider for the periodontal treatment. So in case primary endo is also caused by iatrogenic based on perforation. Perforation repair depends upon the size, location, time, and the degree of the periodontal damage, healing ability, etc. And your vertical root fracture, single rooted tooth lesions caused by vertical root fracture is going to have a hopeless prognosis and should be extracted. Molars can be treated by the root resection or hemisection. So here you can see the base is wide. If the base is wide at the apical region, is the primary endo. If it is wide at the crestal thing, that will be a primary perio. So this is going to be primary endo. So primary endo here, there is a patient with the presence of the sinus opening in mid central incisus. So here they just changed the intracanal medicament and they did nothing for the bone loss. They just did the RCT and you can see the healing response. Okay, so that's why you have to know whether it is primary endo or primary perio. Directly should not jump into perio treatment. Always do endo first. Primary perio, secondary endo, and true combination. So here also, even though it is primary perio, you have to do endo treatment only first. Okay, after endo treatment only, you have to do palliative perio treatment. Palliative means your non-surgical thing. After that, you have to wait and see if there is going to be any resolution. And then, if there is resolution, you can just do root canal treatment. And if there is need of surgery, you can do surgery later. Why we are doing endo treatment first, not perio? Because while doing, suppose if you're doing going to do endo treatment at last, after doing perio treatment, this endo treatment, while doing perio treatment itself, we can remove the cementum, etc. So that thereby this will cause a direct connection between the pulp and the periodontium. So all the irrigants or medicaments, whatever we are going to use in the endo treatment, that may enter in intestinal pupils and that may reach the periodontium. So in that case, it may cause to secondary perio again, okay, even after doing treatment. Or all the microbes which is present inside the pulp that may reach the periodontium and this may damage it again. So that's why always we have to do endo first and consider perio later. So true combined lesion, preoperative radiograph, so pulp test were everything negative. So here they did root canal treatment alone, okay? And even after doing root canal treatment, there is nothing, no change here. Again, patient had similar thing. So what they did, they just did sinus tracing and they did surgery here, periapical surgery, and then there is healing. So we have to do whatever the thing, we have to do primary endodontic treatment first. Then if there is no resolution, we can go ahead with surgeries. And alternatives, there are a few alternatives like resective approach and the regenerative approach. What is this resective approach? Resective approach is going to have bicuspidization, root resection. Okay, so I'll just teach you. Suppose if regenerative procedure is required prior to surgery, we are going. This is for combined lesion or primary perio, secondary endo lesion, advanced stage only. Just only if there is no resolution, or if they like even after 2 to 3 months, if there is only minimal resolution, we have to think about this, either regeneration or resection. Okay. So prior to surgery, we have to do palliative periodontal therapy and root canal treatment. And we're going to reevaluate after 2 to 3 months. So if there is some amount of resolution, you have to go and check for the mobility. If there is more than grade 1 mobility, we can do splinting. If no mobility, no need to do splinting. So after checking this mobility, we have to check the perio pocket. If it is less than 4 mm, non-surgical maintenance is enough. If it is between 4 to 6 mm, shallow defect, then you have to do osteosurgery. If it is more than 6, deep defect, then GTR. In case after doing primary periotherapy and root canal treatment, I'm again saying this is not for all classes. It's for primary perio, secondary endo, and combined only. Okay, when there is minimal resolution or no periapical resolution. In case if there is no periapical resolution, hopeless prognosis, you can directly go and extract, or you can do these 3 procedures. What is this root resection? Root resection is trimming of only one tooth. We are going to completely cut off one root of a molar. For example, distal root. Okay, one root of a molar. And bicuspidization is the tooth we are going to just cut into 2 halves. and we're going to remove only the middle portion, and the distal mesial portion is going to survive. That is only the bicuspidization. Hemisection, you're going to remove one half of the tooth along with the root, both crown and root you're going to remove. That is only hemisection. So these three you have to know, guys. You have to know the meaning of these three. They may ask in your exams. So after doing this, you can just do measure the perio pocket if it is less than 4 mm, 4 to 6 mm, or more than 6 mm, and then definitely have to do follow for 3, 6, and 12 months. So prognosis, as we all know, this primary endo is going to have a good prognosis because it is a confined lesion only inside the tooth, only the pulp thing. So when we do the root canal treatment, it's going to have an excellent prognosis. Primary perio is going to have 4 disease responses. Primary endo, secondary perio. Other all things, it depends on the periodontal prognosis. How is the perio? Because endo is whatever you do, endo just only the tooth. If you do that properly, everything else is fine. But perio is almost everything, the attachment apparatus. So it all depends on the involvement of the periodontal tissue. So to just say as a whole, first we have to diagnose these things, okay, based on all subjective visual. Visual is your what to say? If you have a caries or if you have a calculus, etc., palpation, percussion, vitality. Your endo is going to be non-vital or exaggerated response, and your perio is going to be vital. And probing, as I told you, conical probing and narrow probing for endo, conical in case of perio, GP tracing, radiograph. After all this, you have to exclude differential diagnosis. You have to know about lateral periodontal cyst, vertical root fracture, cemental tears. Okay, you should not confuse all these things with your endo perio lesions. Then you have to do treatment plan. Always do endo first. If you're going to have endo and perio in the same tooth, only endo, do endo, finish it off, that's it. Only perio, do perio. But if you're going to have both endo and perio, you have to do endotherapy first, observe, then you can do periotherapy if needed. And you have to definitely know about the treatment alternatives, root resection, what I told, 3 things: bicuspidization and hemisection, and then root, this one, bicuspidization, root resection, hemisection, regeneration, and endodontic implant. So to conclude, this perio-endo lesion can have a varied pathogenesis, which ranges from quite simple to relatively complex one. To make a correct diagnosis, the clinician should have a thorough understanding and knowledge of this. So first thing, you have to know how to diagnose this lesion. Okay, that is the most important thing. So after diagnosing, then you have to know what treatment should be done. Directly, you should not jump into perio surgery. That is going to like if you do perio first without endo treatment, that is going to again treatment failure because of the endodontic infection. So you have to diagnose properly what class it falls under, then you have to just take it under consideration how the treatment should be done. Okay, these are my references. So I hope you understood these things. I just have few questions. So I'll just show the questions. Please, you can just answer in the chat box. So which is the best clinical tool to differentiate between the endodontic and the periodontal pathosis? Among this, which is the best tool? Percussion, palpation, palpability, or mobility? So any answers? So which is the best clinical tool to differentiate between the endo and perio? Among this? A is not the correct answer. The best clinical tool among this is pulp vitality test. So because percussion and the palpation test, as I told you, this is not going to differentiate correctly. And even mobility tools test, even perio is going to have mobility, and even pulpal thing is going to have mobility. So pulp vitality test is the test which is going to differentiate between the endo from the perio pathosis. And Simon's classification of endo perio lesion is based on what? The type of pathogen. Simon's is the first thing what we saw, the 5 classes. The primary source of infection, the patent route to inflammation, all of the above. Any answers for this? You can just guess. Any guesses? It's very easy. No one wants to guess? Simon's classification of Endo Perio Lesion is going to be based on your source of infection. You have to know whether, what to say, it's primary perios, primary endo, primary perio, secondary endo. It's going to be based on your source of infection. Sorry, my laptop is not working, that's why. And the first one who reports the effect of the periodontal disease on the human pulp. In history, I've said that is your Turner and Drew. Turner and Drew is the person who reports the effect of the periodontal disease on the human pulp. And what is this procedure in the picture? Any guesses, guys? It's very easy. Root resection, hemisection, regeneration, bicuspidization. This is a one particular tooth which is divided into two portions. They have removed the middle portion. This is not hemisection. Hemisection is we have to remove one half totally. If you are going to remove this fully, that's only called as hemisection. This is the bicuspidization. Okay, we are just going to remove the middle portion alone, and the two thing is intact. So this is bicuspidization. Fine. So here, what is the diagnosis for a patient who visited with mobile 3-6? Clinical examination showed no tenderness and percussion palpation and a 9 mm probing pocket depth. So, and the radiographic examination showed no periapical change. Here, there is no periapical change and there is only probing pocket and mobility. So, what could be the thing? Primary endo, primary perio, primary perio, secondary endo. You can just guess. It's okay even if it's wrong. There is no tenderness on percussion, and there is, if there is going to be a probing depth, definitely it's going to have a primary perio, right? So this is going to have a primary perio infection. So when it is not possible to determine the primary infection in Endo Perio Lesion, the treatment is aimed at eliminating. So what could be the answer? What you have to do first? Endo or perio or both simultaneously, periodontal followed by endodontic infection. So what is the answer for this? Which you have to do first? Yes, it's correct. So always we have to do endo treatment, okay? Everyone can answer. Please, everyone post an answer here. So first, always you have to do endodontic infection first. And if there is no resolution, then only you have to go for periodontal infection. Which of the following is the characteristics of the pulpal infection? Which of the following is the characteristics of the pulpal infection? Localized bone loss, angular bone loss, sinus tracing laterally, all of the above. So what is this? Localized bone loss, angular bone loss, sinus tracing laterally, all of the above. So if it is going to have a pulpal infection, there will be localized bone loss only. The correct option is answer A, only localized bone loss, okay? Really sorry, there is some delay here. And which of the following pathogen is common in Endo Perio Lesion? Aggregative Bacteriacnomycetum commitans, Candida albicans, cytomegalovirus. What is the answer? Any guesses? Yeah, this is correct. Aggregative Bacteriacnomycetum commitans is there. But the thing is, also Candida albicans, cytomegalovirus is also going to be there. Okay, so all three is going to be there. So this is a tricky question. So everyone knows this answer A is correct. But also you have to know this Candida albicans is also there and cytomegalovirus is also going to be there. So the correct answer is going to be all of the above. Okay. And your next question here. So I'll just read it out since it's not working. Just two more questions. So can you understand so far? Like, I think you have few confusions. Just about the procedure, hemisection, etc. Okay, the next question is deep periodontal pocketing with localized destruction of alveolar bone in the picture, which is related to. So if you're going to have a deep periodontal pocketing with localized destruction of alveolar bone, what it is, endo or perio? Just answer in the chat box. Endo or perio? Deep perio pocketing and with localized destruction of alveolar bone. There is not generalized destruction of the bone, and there is deep pocketing. Just tell it's endo or perio. Yes, endo, it's right. So if you're going to have a deep pocket, it's definitely going to be an endodontic infection with localized destruction. Okay. And the next question is, if you're going to have a wide base at the apex, this is what infection it could be. Wide base at the apex. The radiograph, there is wide base at the apex. Endo or perio? Perio? No, not perio. See, if you're going to have a wide base at the apex, that is an endo. Okay, because that is the thing for the periodontal periapical changes which could occur in endodontic infection only, not perio. Perio, there will be a wide thing at the coronal structure, not at the apex. Okay, so that's it. I hope you understood something. This is a complex topic, guys. So don't worry if you are too little slow. It's not an easy thing. So it takes some time. You just revise it again and again. So you'll just get it. But also it's an interesting topic. So you can just know about it in depth. Okay. Thank you.